Good morning or afternoon, depending upon where you're joining us from. My name is Ann Greiner. I'm President and CEO of the Primary Care Collaborative. And for those of you who may not know the PCC, we are a multi-stakeholder organization committed to improving the nation's health by strengthening primary care. Today's webinar is focused on scaling access to contraceptive care in primary care, and we're pleased to partner with Upstream USA today for today's conversation. A few housekeeping items before we get started. This session, like all of our webinars, is being recorded. The recording and slides and any additional materials will all be posted on our website, thepcc.org, within 48 hours after the webinar is over. You'll find all of our webinars on our website, so please take advantage of them. We'll also be taking questions from all of you using the Zoom Q&A. For most people, it's found on the bottom of the screen. We're going to have a conversation with some terrific panelists today and allow 10 minutes at the end of the discussion for your questions. At the end of the webinar, popping into your email will be a survey, and we very much would like you to fill it out. We want to gauge interest in this topic across the primary care community, and your input is going to be critical to helping us understand where interest lies. Now let's turn to the topic for today's webinar. I think when we reflect, contraceptive care is broadly recognized as one of the most important public health innovations of the 20th century. But there have been recent significant changes in reproductive health care access, and they've had some effects on the accessibility of birth control. We're going to examine these issues today and what some of the solutions may be. In particular, let's focus on this startling fact that 19 million women of reproductive age live in a contraceptive desert. And by what I mean is that they lack reasonable access to the full complement of contraceptive options. In parallel, nearly half of US counties in the States do not have a single OB/GYN. So this obviously limits access, creates contraceptive care deserts, and reduces the likelihood of patients receiving the reproductive health services that they need. It also can raise some equity barriers for patients who can't afford to take time off for work, find childcare, or arrange transportation to go perhaps far afield to get the necessary contraceptive appointments. We know that specialists play a critical role in family planning provision, and they always will, and they're a very important part of the solution. However, when we look at studies about where women of childbearing age and others are getting their care, predominantly they're getting their annual wellness visits and well women visits from primary care clinicians. In fact, a study that the Kaiser Family Foundation put out found that 79% of women reported having a general checkup in the previous 2 years, which is very good in my view. And most of them were being seen by a primary care clinician. In contrast, only 42% of women reported having a gynecological exam during that period, or actually this is within the last 12 months. So when you think about it, while OB/GYNs are very important to the care of those seeking contraceptive access, we also can see that primary care can help to broaden that access and is a really important part of the solution to those that are in healthcare deserts or even in counties where there is access, but perhaps not enough access. Our mission is to really deliver a comprehensive team-based approach to primary care that meets patient needs. And we see contraceptive care as part of comprehensive care. It is important that those of childbearing age are able to get the contraceptive access that they need. All right, now I'd like to introduce this fabulous panel. We have three panelists today for this conversation. First, I'd like to welcome Jess Marcella. She is a longtime advocate of reproductive health rights and justice. Many of you may know Jess. She's had several policy and advocacy roles that are highly visible. Most recently, she was Deputy Assistant Secretary in the HHS Office of Population Affairs. Welcome, Jess. Next, I'd like to introduce Dr. Angeline T., and she is a board-certified family physician with a subspecialty training in family planning, who serves as clinical advisor for Upstream USA, and a faculty member at the Wellstar Douglas Family Medicine Residency Program. She's also a guest researcher at the CDC Division of Reproductive Health. Welcome, Dr. T. And last but not least, we're thrilled to have Dr. Julia Strasser. She's director of the Jacobs Institute of Women's Health and an assistant research professor at George Washington University School of Medicine. Julia's research focuses on contraception, abortion, and access to care for underserved populations. So welcome to all of you, and very excited for this conversation. Jess, let's start with you. In your role as former Assistant Secretary for the Office of Population Affairs at HHS, I'm wondering if you can just set the context for all those who have joined about the current state of contraceptive care across the country. Who are the major players? Where are folks going to get care? And what are some of the access challenges?
Thanks so much, Anne, and thank you for having me. You really covered a lot sort of in your intro, but I think it's important for people to reflect on the fact that there are roughly 65 million women of reproductive age in this country, and almost a third of them live in a contraceptive desert. What we knew from our experiences running the nation's family planning program is contraception is a point of entry to care for people. So 4 in 10 women who would come to the Title X family planning clinics would cite it as their sole source of care in a given year. And for 6 in 10, it was their usual source of care. What we know is that there are diverse settings with clinicians that offer contraceptive care, local health departments, Planned Parenthood clinics, federally qualified health centers, and other community health centers. Really, this notion that contraception is just for specialists is something that is not what bears out in our nation at this stage. And so I'm really glad to be here to have this conversation. And it continues to be the fact that there is not enough contraceptive access in this country, even though we have lots of individuals going into lots of doors to seek that care. And I didn't even mention, increasingly in some states, we're seeing people just going to their local pharmacies for their contraception. So wanted to make sure to add that too. Thanks.
Thanks for painting that picture. It really is a very varied settings and very varied types of clinicians that are responding to the need for contraceptive care. Angeline, as a primary care physician who specializes in family medicine, I'd love to hear your perspective on the contraceptive care workforce and the role that primary care plays.
Sure, and I'll also echo a thank you for having me, and thank you for all the participants for coming and learning about this topic. I think this is a perfect topic to be discussing today. And so I guess I'll start with maybe just talking about really just how well suited primary care is to providing contraceptive care. In thinking about contraceptive care as something that's time sensitive. Right, that when somebody needs it, they sort of need it pretty quickly, where that care really needs to be patient-centered for it to be appropriate and non-coercive and high quality, and also where patients' needs change throughout their life course. And I think this resonates really well with some of the strengths of what I see as the real strengths of primary care, which is a field that focuses on accessibility, on continuity, and on forming genuine connections with patients and their families. And so I think that's where kind of the synergy of contraceptive care and primary care really kind of it's a no-brainer. And so, when I think about expanding access to contraceptive care, again, primary care is a no-brainer. It's an existing workforce that is already focused on working with communities, working with underserved populations. I think we're a field that really tries to address access across multiple different domains. I think we've talked about contraceptive deserts, which often is sort of geographic, urban versus rural access issues. But obviously, there's also financial issues, linguistic barriers to care, things like that. And I think primary care, we really do our best to address those issues as well. And it's also primary care is just an existing workforce that really work. Again, I'm biased here, but I think we really do everything that we can to meet our patients' needs, and we can take a really strong role here in triaging, what patients might need referrals to more subspecialized contraceptive care, which really is not going to be the majority of patients, and really provide the vast majority of contraceptive care within the patient's medical home. I think maybe the last thing that I'll say, because I can't help it as a residency faculty, but when you say workforce, I also can't help thinking about the pipeline. My family medicine residents are all interested in learning more about contraceptive care. I'm kind of their reproductive health person, so I really do my best to provide good, strong teaching in those domains. And my residents are, and family medicine residents, I would say, many across the board are really eager to provide this care for their patients and not to have to refer out. But when I think about my graduating residents and those who are a few years out in practice, what they really need is for the practices that they go into or the health systems that they're working in to really support them in providing high quality contraceptive care, having existing structures, existing systems, just a culture of having contraceptive care within primary care. And if that's not there, then many of them eventually stop providing care just because it's too much of a lift to try to get whether it's procedures or other types of care within their practice.
Well, thanks so much for those comments. I mean, a couple really resonated with me in the work that we do. One is the diversity of patients that primary care sees and its adaptability, depending upon what the patient needs are. I mean, I think that's one of the incredible strengths of primary care, that it is very responsive to, or ideally very responsive to community needs. That's really important. And I think another issue you've raised is, many practitioners like yourself are trained for a broad scope of, provision of a broad scope of services. But if you're not regularly given that opportunity to provide such services, your skills can begin to atrophy. And then what is available to the patient is narrower, right? And ideally, what we know is most patient-centered and most cost-effective is to have this very wide scope of services, so that when people come in the door and they ask for X, Y, or Z, you're able to provide it. And that does mean you need to have certain supports in the practice where you're working, and also a payment model that supports this provision of a wider scope of services. So thanks so much. Great reflection. Julia, you are a researcher, and so probably been following trends in contraceptive access. What can you tell us about what you've learned through your research and the research of others?
So I'll add my thanks for inviting me to be part of this discussion. And as you mentioned, I'm a researcher. I'm one of the lead researchers on an ongoing project that's designed to understand the national workforce that's providing contraception and abortion in the US. So I'm planning to talk about some of what we found in that research. I'm happy to share links to any of our manuscript or to our project website if anybody wants any more details about what we found. But in order to answer your question, we conducted a study of the contraception workforce across the US. We found significant differences in the scope of contraception care by specialty. So while about 73% of OBGYNs and nurse midwives prescribe the contraceptive pill, patch, or ring, only about half of family medicine physicians do, and less than half of other primary care clinicians do. And we also looked at the specialty mix of physicians that were providing IUDs, implants, and the shot, which is sometimes also called depot. And we found, again, most OBGYNs, about 93%, were providing IUDs, while about 16% of family medicine and less than 3% of internal medicine or pediatricians were providing them. But even though we found that primary care clinicians were less likely to offer the full scope of contraceptive services, I want to also point out that there are significantly more family medicine physicians in particular across the US. So even though the proportions are lower, what we found is about 72,000 family medicine physicians who are prescribing contraception compared to about 37,000 OBGYNs. So, we know from previous research that family medicine physicians in particular are more likely to be located in rural and underserved areas. And so it's important, to understand that these clinicians, these primary care clinicians, really are a key component of the contraception workforce, and even more so in certain communities like Dr. T just referenced. And also, I just, to be clear about the goal of our work, it's not sort of a pointing fingers or a shaming exercise of saying primary care providers, why aren't you, all doing this? But instead, how can we provide support and training and policies that can be supportive for this critical segment of the contraceptive care workforce? And I'm sure that's what we'll get into as we continue the conversation today.
Thanks for that overview. It really is remarkable to see the differences in types of services, but then also to recognize you have a larger workforce with primary care. So hence the focus of this conversation. Patients now realize that there's a whole breadth of types of contraceptive services that ideally they have access to, but if they go into an office and that's not available, then how patient-centered are we? So, there is that gap there. And for lots of reasons, people want, that kind of broad choice and broad access. Angeline, I'm wondering if you could reflect on, ideally, what kind of standard should we strive for? You're training residents, you're thinking about the kind of things that you would hope any family medicine physician would be able to provide in the community. And maybe we want to think more broadly: family medicine, internal medicine, GPs, whatever you'd like. What should be our standard when we think about the range of services that would acquaint with comprehensive patient-centered contraceptive care?
Sure, and thank you for recognizing my bias is towards family medicine, but kind of recognizing that primary care is a diverse and beautiful kind of coalition of family medicine, pediatricians, internists, nurse practitioners, and many more. Right. So exactly, PAs. So it's all, not to leave anyone out. Yep. And so, I think in this conversation, really, so I guess maybe speaking to that is a broad range of providers with a broad range of training and a broad range of potentially even, I think I'll talk a little bit, kind of procedural comfort, things like that. So we're talking about, a big umbrella, I guess I'll say that. So I think sort of just in thinking about sort of standards and sort of what should we expect from everyone. And I think that should get down to sort of like what I would say is maybe the philosophy or the grounding of contraceptive care, which we have from high quality, respected organizations like the Office of Population Affairs, CDC, ACOG, to say that care must be patient-centered. It must really center the needs, values, and preferences of the patient. It means that care should be evidence-based, non-coercive, trauma-informed, and really rooted in shared decision-making. And so I think that's sort of like maybe thinking of like the umbrella sort of philosophy that this care should be delivered under. And maybe to sort of, I think in talking about sort of ideals, the true ideal is also to recognize, right, that while we're here to talk about contraceptive care, that is part of a continuum of reproductive health care, that, in the true ideal, we're supporting folks through their pregnancy needs, their prenatal needs, and supporting their pregnancy related decisions kind of across their spectrum. But I think talking specifically about contraception, what I would say is, what the ideal PCP should really strive for is really kind of like what we do with other aspects of primary care, is to really be able to meet the vast majority of their patients' needs. I will say that I think this doesn't mean that every single PCP needs to be trained in procedural care like IUDs and implants. I think what we know from the numbers, from national surveys of what patients are using and how, what proportions, is that likely there isn't sort of the demand for every single primary care provider to need to provide this procedural care. And I think I would also even caution for any efforts around that, because I think that would likely dilute the quality of procedural care. But I would say all PCPs really need to be comfortable with patient-centered contraceptive counseling, really need to be familiar with what methods are available and how to either provide those methods or refer for those methods in a timely manner. They should be able to utilize high quality evidence-based guidance. I think kind of the bread and butter that I think of as the contraceptive guidance really is the CDC contraceptive guidelines, called the medical eligibility criteria for contraceptive use and the selected practice recommendations. But these recently updated guidelines really kind of provide, I think, a strong foundation, again, that all PCPs should be aware of. And kind of having this foundational knowledge and skills really is going to be able to help a PCP be able to support a patient, through their decision making to start a method, to stop a method, to troubleshoot side effects, and to really help patients figure out what's going to work best for them as their lives and priorities change.
Thank you. I have a follow-up question for you. So what do you think are some of the barriers in practice, that primary care clinicians of all stripes are generally facing, that they are not able to provide this broader range?
So, I mean, I think one barrier is definitely training. I think, speaking from, I guess, the medical perspective, but we can only cram so much into our residency program. And a lot of learning and training still needs to happen sort of after graduation, right? And so I think that's true of all kind of primary care clinicians. And so I think being able to have robust training that happens during formal training, but then also that's available afterwards, I think is part of the issue. I think other barriers include, as I alluded to, also kind of just like structural barriers. So if you are trained to provide procedural care and you want to provide it, how do you work that into your, if you're working at a place that has either, just 15-minute appointments, 20-minute appointments, if you see a patient and they want it now, how do you help meet those needs? And then, just I think the other barrier may potentially come from the patient as well. So I think, I won't trying to keep this short, but like how I feel like what we learned from screening for depression is that we didn't really know what the demand was until we started asking about it. And so, and patients don't always know that they can go to their PCP to talk about depression or to talk about contraception. And so, so part of it is, making sure patients know, and that know that they can talk to their medical home about this, and to, potentially then screen for these needs to make sure we're not missing unmet needs.
Yeah. Well, patient-centered can often mean, can we have a one-stop shop so that I don't have to yet go to another appointment, find childcare, take time off from work, et cetera. Like, couldn't you just do this for me today? I mean, it can be as sort of straightforward as that, and there's lots of reasons why that doesn't easily happen, but thank you. Julia, there's been a lot of recent changes that have affected the healthcare workforce of all kinds. COVID-19 was a sucker punch to those practicing in hospitals, but also in ambulatory care. And then there's also been some recent reproductive healthcare restrictions. How is that affecting the workforce that is providing contraceptive care?
Yeah, so I'll talk about COVID first, and I think sucker punch is a good way to describe it. I think it's fair to say that there was an enormous impact on the workforce broadly from COVID-19, and I think that many clinics and health systems are still recovering from that now, whether that's trying to ensure that they have a full nursing staff or addressing rising rates of burnout among clinicians. One of the things that we found in our research is that the number of physicians providing contraception dropped in 2020, but then rebounded in 2021, but hasn't actually didn't come back to pre-pandemic levels. But what we did find was an increasing number of advanced practice clinicians like nurse practitioners and physician assistants who are a key part of the contraceptive workforce and a growing part of the primary care workforce more broadly. And in other research, we found that the number of advanced practice clinicians providing contraception care increased again in 2022. So, as the workforce is shifting potentially towards greater proportions of advanced practice clinicians, we also have to think about what policies are in place that may be either supporting or hindering that growth. So NPs and PAs in particular can be limited in the types and scope of service that they can provide due to scope of practice restrictions that are determined at the state level. So that's, a little bit of what is happening related to COVID. The changes that took place during COVID also followed on the heels of a very damaging Title X regulation in 2019 that I'm sure Jessica could speak about in much more detail than I can. But clinicians already in 2020 and 2021 were managing these sort of multiple layers of stressors on the workforce. And then in 2022, with the Dobbs v. Jackson Supreme Court case, we know that there are likely to be impacts across the healthcare workforce, not limited to abortion, but extending into other areas of reproductive health and healthcare more broadly. And I think some of those, were immediate, but some of them were really just starting to understand what the effects of those workforce issues are, because research, takes a while to understand kind of the full impact there. And so we're thinking about all of these various external factors that are putting pressures on the workforce, and then saying, also now you have to provide contraception, and also now you have to provide mental health services, and sort of all of these other things, I think can put primary care clinicians in a really difficult situation if we don't also have supportive policies that can kind of address these system level issues.
Thank you. So I think we've all just heard about a number of issues that are having an impact on contraceptive access. I mean, COVID was hopefully a 1 in 100-year event. Who knows? That had a big impact on the workforce. We're also hearing about some structural issues that Dr. T raised, training challenges. It seems like there's always trying to get more and more into the training curriculum, and that's very challenging. And then I think there's been some policy changes which have also had an impact. So Jess, what does it all mean for patients? All of the, we've kind of talked about this from a clinician point of view, some of the stressors and barriers. What does it mean for patients?
It's such a good question. And I think it means different things for patients. What I would say is, I think at the individual level, we know that there's a chilling effect that is happening. And yet when you sort of look at the macro level, it reinforces for me and so many others in public health that this is sort of a critical time in our nation's history. Because when you think about access to contraception for patients, it's not just the direct impact on pregnancy and birth outcomes, which are important. And, we often talk about how the US has some of the worst maternal mortality rates in this country, and the impact that pregnancy and birth spacing can have to improve those outcomes is well known and well researched. But beyond that, when you think about contraception for individuals and for patients, you really recognize that it has an impact on well-being, on the ability to work, on the ability to make sure you have the resources in your household and make ends meet. We often talk about the social determinants of health and how an unintended pregnancy can really derail a lot of sort of the other aspects of health that individuals and patients are facing. And so what's really challenging, but an opportunity here, is we have to recognize that patients are absorbing this all right now, and that they are coming to primary care as their trusted clinicians who can help them navigate what seems to be a never-ending series of puzzle pieces to put together here. And so, you know, just the work that I think primary care does every day to support health and well-being is really one of the reasons why I'm so glad we're having this conversation about why contraception matters for patients and why primary care has a real opportunity to not only sort of buttress the public health landscape, but really bolster health and well-being for patients.
Thanks for that. I think you all have alluded to a lot of things in the environment, whether it's policy, structural, a pandemic, and patients may not always understand, why all of a sudden they're facing restrictions or they can't get the care that they need. And this can lead to mistrust in medicine, frankly. And that can be really problematic for that individual's health, but also for the health of the nation if people start to distrust, medical providers. So I do see a really important role for primary care, helping to educate patients about what's happening and how to partner with them to figure out, how do we address these challenges. But beyond patients, which is obviously really important and critical to understanding, I'm curious, Jess, you've had important roles at HHS. What should be a federal response? What, if you could wave your magic wand as a former federal leader, regardless of who's in the White House, what would you say are some things that the federal government should do to respond to the set of challenges?
Oh, I love the magic wand question because there are so many opportunities for the federal government to be supportive here. I think I often say that coverage without access and access without coverage is meaningless. And so to the extent that the federal government is supporting, subsidizing high quality patient-centered contraceptive care, it's really valuable. Within the Title X program, we had less than a third of what we needed to serve all patients in need of publicly funded family planning care. I think beyond that, the opportunities for the federal government to support training initiatives around these important topics is really, really valuable. I think the federal government's role increasingly in sort of public education around standards continues to be valuable. Angeline mentioned obviously the medical eligibility criteria for contraceptive use and the selected practice recommendations, which is really meant to be a handy tool for clinicians to know exactly how to support patients in need of contraceptive care. My office put out the Quality Family Planning Guidelines, which really helps also define what quality should look like in a contraceptive visit. And I hope that people will look at that. That was actually recently published in the American Journal of Preventive Medicine in just the last couple of weeks. And then I think beyond that, there are real opportunities when you think about, public insurance to make sure that there is full coverage. We know that, there are still populations that are left out of contraceptive coverage where there's real opportunity here. And I think just any sort of effort recognizing that patients go to any number of settings for this care to make sure that there's the support, the resources, the funding, and the supplies to make sure that patients could get what they need would be really, really valuable. I have a million other suggestions, but that's probably my top 10 in my magic wand list.
Well, thank you. It's good. It's always good to have a list. And to be ready when a decision maker says, well, how would you change this, right? So it's very important to have this dialogue. I'd love reactions from Julia and Angeline to what Jess has put on the table and any additional ideas that you might have for federal policy.
Sure, I think you may hear some common themes here. Before I guess I get into sort of state and federal policy solutions, I think I like to mention this kind of anytime we talk about contraception, because I think it's important. You know, if the ideal scenario here is for all individuals to have access to the full range of contraceptive methods, but we also have to think about solutions in the context of other factors like mistrust of the medical system, like as you mentioned, and systemic racism. And we know from research that clinicians often treat people of color in biased ways related to reproductive health care, including pressuring Black and Latino women in particular to limit childbearing or to choose, excuse me, a contraceptive method that's based on provider preferences rather than patients. And so I say that because as we're thinking about policies to help address these workforce challenges, it's important not to have a sort of more is better approach or to inadvertently incentivize offering certain types of methods over the others. I think Jess covered a lot on the federal side. Title X is a critical but chronically underfunded program. For Medicaid, I would say there are well-documented challenges about the primary care workforce, including the same sort of patterns that we talked about with primary care clinicians not being able to offer the full range of methods, but then with additional layers of complications like fewer clinicians who accept Medicaid in the first place. When we think about sort of improving Medicaid acceptance for clinicians, you know, one thing we know, and Dr. T mentioned earlier about residency training, is we know that clinicians who do their residency training in a setting where they treat Medicaid patients are more likely to accept Medicaid in their post-residency practice. We know that from a lot of research. There's a program called the Teaching Health Center Graduate Medical Education Program that was focused on providing care to underserved and Medicaid populations. And that's a program that could be expanded with additional federal funding. We also know that residency programs with required integrated training on contraception in their curriculum produce graduates who are more likely to provide the full scope of contraceptive care. But those programs have not historically been federally funded. And so replicating those types of programs and bringing in federal investments would create more opportunities to train the future workforce. A couple other things, because I also have I always have a list. We talked about the role of federally qualified health centers, also called FQHCs or community health centers, which are critical providers of primary care services for underserved populations, including contraception. But many of them face staffing shortages and reimbursement challenges that are specific to the community health center setting. And so addressing those challenges for health centers in particular, I think is a way to improve access to contraception in the primary care context. And then I said this before, but I'll say it again. And I think that at the state level, scope of practice restrictions for nurse practitioners and PAs in particular, we know that advanced practice clinicians can safely and effectively provide most methods of contraception, but many state policies require them to have oversight from a physician, which places additional burdens both on advanced practice clinicians, but also on the physicians who have to provide oversight in a way that's not clinically necessary. So I'll pause there and pass it to Dr. T.
I just want to plus one kind of all that Jessica and Julia already said. Definitely, you know, I think specifically, which one did I? So kind of, especially thinking about what kind of potential quality metrics, you know, might we want to think about what is related to contraception, but being very mindful that, you know, the last thing that we want to do is to incentivize coercion or to incentivize kind of systemic racism. So I think, you know, putting that out there and thinking about how balancing measures or like measures can be used together, or that ways that we can implement kind of strong measures that look at patient satisfaction. So I think those are things that I wish I had more expertise on, but, you know, definitely, you know, like think that we really need to think critically about. more like, I guess, not practical, but I'll say, I'll say provider, clinician centric things. Reducing administrative barriers. I think the Affordable Care Act went a long way to reduce things like prior authorizations related to contraception, but they're not. They're still there. An example from my clinic is that our clinic still requires essentially an authorization for IUDs and implants. And many clinics that Upstream works with does as well. And looking at the data, the vast majority of insurance plans do cover IUDs and implants without cost sharing. But then when you look at maybe a year's worth of data in a clinic, maybe there's one that was denied, or and then that creates that creates an absolute unnecessary barrier. I think thinking creatively about ways that, I guess, hopefully federal or state policy could potentially reduce barriers to training, especially procedural training. Because I think, on the one hand, getting CME to learn about new contraceptive methods is relatively straightforward. But once you're done in formal training, getting hands-on procedural training is quite challenging. There's issues around malpractice coverage, things like that. And so if there were some creative ways to provide supports or again systems in place to reduce those barriers, I think that would be incredible.
Wow, we have covered the waterfront here. Everything from how do we better train our workforce and where should they be trained to get exposure to the range of contraceptive services, to issues related to scope of practice, to insurance coverage. How do we incent through payment models and quality measurement, being very mindful of making sure that the measures don't result in unintended coercion of patients. Medicaid and its role. I mean, I can go on and on, but before we turn to questions, I just want to come back to sort of making sure that folks who are on this, joining us for this conversation today, really hear directly from you all. So we've got a range of people who are in our audience, if you will. They're reproductive health advocates of all stripes, clinicians of all stripes, healthcare administrators, health plan administrators. So, very briefly, I'm just going to go one-to-one. Why should every healthcare leader care about expanding access to contraception? All right, I'm going to start with Julia.
Well, as you heard earlier, but it probably bears repeating, we know that contraception is associated with a number of health benefits and other benefits like higher earning potential and quality of life, but also it's critical for self-determination and bodily autonomy. So what we need is access to contraception without additional barriers. And I think part of that is access to a robust primary care workforce that can offer the full range of contraceptive methods. And just to go back to something that you mentioned at the beginning of the call, only 60% of US counties have either an OBGYN or a nurse midwife, while over 90% of counties have a family medicine physician. So I think the conversation is really about providing support for the clinicians who are already out there and taking care of patients like we've talked about, as well as expanding the workforce to include others who are trained and qualified to provide this important care.
Thank you. Okay, over to Jess.
I knew you were going to pick me. It was hard for me because I think what Julia said was so valuable, right? This notion of if, when, and how to expand your family, like that's fundamental to who a person is and who they may choose to become. And I really believe that anyone in healthcare, I'm so grateful for you because you really are here to help people. So sort of centering that notion that this is about people sort of choosing who they are and who they may be able to come in the future is really valuable. And while contraception is just one aspect of that, it really is a critical one. And if I can put one little editorial point, we have only talked about it in the context of women's health, really. I have done that. But contraception is for men. It is about families. It is about communities. And so really sort of taking that expansive view about the wide, spread impacts contraceptive care can have is something that I think is important for everyone. It's in every household. It has an impact on every person in some way, shape, or form.
Well, thanks so much for bringing it back to the patient and making that very, very clear. Dr. T.
I'm trying to come up with kind of I'm not sure what my true answer is to this. I mean, I think part of that is because, I think maybe I want to argue like the opposite. Like why is it okay to not care about contraception? We don't say that it's okay as a primary care provider to not treat diabetes. This should not be a separate carve out. This is something that is common, that is important, and that really helps patients, again, meet their reproductive goals. It helps facilitate reproductive autonomy. This is sort of a no-brainer. And so, it's sort of, there's a million reasons why, and that this is really how we can better serve our patients.
Super. Okay, we're now going to take your questions, and a lot of them have been streaming in, and we'll try to get to as many of them as possible. So if you all can, there's a lot of questions. So if you all can keep your responses sort of short, and not everyone has to respond to the questions. One question is, who can tell us a little bit about where insurance coverage gaps keep people from getting the kind of contraceptive services they want? Okay, go for it, Jess.
Okay, I'll hop in. I mean, listen, again, the Affordable Care Act made great strides in terms of this notion that contraception should be covered without cost sharing. It wasn't for all plans at that point, right? There are some plans that are grandfathered. And then even to get more granular, it was that one of each type of method should be covered without cost sharing. But really, with contraceptive technology, there are more methods that are coming onto line that patients want to access. And there is sort of variability even within a same method category about something that is so sensitive and so individual and like how it may impact a patient. And so I think when you take that in context that like you can get some things, not necessarily all things, which is the way that insurance works, that adds a particular barrier. And then, there are those areas that aren't covered. So we were talking earlier today, actually in a separate conversation, about how if you're not a dual eligible, but you're a person on Medicare because you have SSI and you have a disability, you may not have coverage of contraception because people think of Medicare as only for people who are 65 plus and therefore no longer in need of contraception potentially. And realistically, we also recognize that insurance is complicated. Insurance plans themselves might be very expensive and out of reach. So it's not even what the plan covers. It's like, can you afford insurance itself? And so taken together, all of those little elements mean there's so many gaps that we could fill, but the conversation isn't that granular in some settings right now.
Yes. Thank you for that. I mean, I think we all have to remember that you can have insurance coverage, but the financial barriers may be such that you can't avail yourself of those services. So that's a reality, not just for low income individuals, for middle income individuals too. I mean, I think it really is. Okay, a question from someone related to state policy. Several states, including mine, are facing the possibility of quite dramatic Medicaid cuts. What are the implications in we've had these conversations before under different administrations. What do you think the implications might be for contraceptive care, and how might the community prepare for this? I'm looking to Julia, who I think is also does some research on state policy.
Sure. Yeah, I'll hop in with some thoughts and then anyone else feel free to add any. So I think not just Medicaid cuts are definitely a possibility. I think there's conversations about block granting or capping the program or imposing work requirements. And all of these things have to do with people being eligible to get Medicaid coverage in the first place, right? So that's a challenge, just like what Jess was talking about of do you have the coverage and then can you use it, sort of are related but two different questions. I think the implications for contraceptive care are, we know that it will make it more difficult for people to be able to access the care that we need. I think also the more burdensome the requirements are for Medicaid on the clinician side of things, we already know that there is this challenge of being able to have clinicians who accept Medicaid. And so I think if it becomes even more burdensome, it's possible that clinicians will choose no longer to accept Medicaid. And then the contraceptive care workforce for Medicaid patients in particular may shrink even further. I'll stop there because I know you asked us to keep them quick and see if anyone else wants to add anything.
Anybody else on the state level and what might be coming and how folks may prepare for a different environment?
So what I would just offer is that we know that many states are facing deficits in the same way that the federal government is. And that is not a new proposition, but it is an ongoing and increasingly problematic proposition where, those who are working in state government are having to make very difficult decisions. I think how that translates into this particular conversation is around reimbursement rates. And, the reality is those who are serving in the safety net, they're very thin margins on which we operate anyway. I think the best way to prepare, the good news is that family planning is a core service in Medicaid. My expectation is that will continue to be the case. And so the preparation is sort of more so focused on knowing that when there are so many competing healthcare and public health priorities, how to continue to elevate this in those conversations so that it can continue to receive sort of the same recognition that it has had for decades.
If I could just kind of open the aperture for a moment, and this relates to this conversation, and there are more questions, and I will get to them. We talk about constrained resources, but at the same time, it seems like every year, the amount of money we're spending on healthcare continues to grow. At the Primary Care Collaborative, we look at that and have conversations with policymakers about are we spending on the kinds of services that are actually going to produce health, services that are focused more on prevention, like contraceptive care and health promotion, and management of chronic conditions? Or are we just, do we tend to shortchange those kinds of services and then provide a lot of services when people, need more specialized services and acute care services? So, our system is really producing a lot of healthcare services. It's not producing a lot of health. And consequently, the costs keep going up because we're not keeping America healthy. And I see contraceptive access as part of the health prevention and health promotion part of the equation. So, in the Primary Care Collaborative's view, we need to shift dollars to those kinds of services that keep us healthy. And I really think of contraceptive care in that umbrella. So, questions come in about the role of professional boards, whether it's for physicians or nurse practitioners or PAs. What role might they play in ensuring that medical professionals are competent to provide a broader range of contraceptive care services? Maybe Angeline, you'd like to take that question.
I can definitely, I can take a stab. I think absolutely professional boards could do more, whether it is simply incorporating more contraceptive questions into board exams, which makes somebody study for them, things like that. But, also, at least in Georgia, I saw, with a few years ago, at kind of the peak of the opioid epidemic, our medical board instituted a requirement that you needed to get training on that, 8 hours of training, and attest to that before you could renew your license. So there are definitely levers like that, that I think professional boards could lever. But even without like the specific requirements, because I think it is, again, given the diversity of primary care providers, it may be harder to find something that really like 100% works for everybody, but also to share resources, and to provide, whether it is like, a webinar or some other types of training that that clinicians can easily access. I think is definitely another way that professional boards could work, as well as collaborating, I think, across boards and sharing strategies and resources as well.
Super. Thank you for that. We're really in the process of wrapping up here, but I do want to throw something out and get your final reactions. As we move into a new administration and a new Congress, it does seem to those of us at the Primary Care Collaborative that there is this opportunity to address what is being raised on both sides of the aisle, which is the declining health of the U.S. population. More people are faced with chronic conditions. More people are perhaps not getting all the preventive care that they need, foregoing things because of the financial barriers. I guess whenever there's a change in the administration or a new Congress, everyone is, wondering how things might move going forward. But we see an opening of a shared understanding that we keep spending more and more and more money, but our population's not getting any healthier. So I'm hopeful that in the years ahead, we can actually come up with some bipartisan solutions to address these sorts of issues. If anyone would like to jump in on that final remark, I'm happy to open it up.
I was just going to say, beautifully said, right? And in Washington, prevention doesn't score, but I think we continue to understand the really important role of prevention and health promotion. And so I do hope that in the years to come, whether they be in 1 year, 2 year, 4 years, 10 years, that we sort of move towards a policy stance in our nation that really reflects what we're seeing in service delivery.
Thank you. Thanks for that close. Please fill out the survey when it pops into your email, and join me in thanking these terrific panelists for such a wonderful conversation. Have a great afternoon.